when we're doing a more respiratory exam, our respiratory exam consists of, an upper airway, which is delineated from around here where the Adam's apple is up here above it, above that glottic opening will be an upper airway, including the hypopharynx, the oropharynx, the nasopharynx, the nasal cavity, as well as the oral cavity. So in a respiratory exam, we're checking the upper airway to see that there's no any obstructions or anything that could cause any issues with allowing air to come in to the upper torso and to get exchanged into the lung parenchyma so that we can have carbon dioxide and oxygen exchanged. We particularly pay more attention to a lower respiratory assessment if we know that the patient is actually complaining of shortness of breath and is more of a medical emergency such as asthma, COPD. The upper airway, we would think more of some type of foreign area body obstruction. It could be something even like epiglottitis or croup, those kind of things, upper airway. But as we come down from the upper airway, go down to the lower airway. In the lower airway, we still are checking the neck area again, like we said. So you're looking for any type of tracheal shift or lateralizing movement of the trachea. We're looking for a jugular vein distension in the neck. Now, this is usually checked at a greater than 30-degree angle as they sit semi-fowlers, because the venous drainage does come from the cranial cavity back down to central circulation and enters back into the atria, the right atria. So laying flat, this decreases the actual pooling, and you'll see that the neck veins may be enlarged or engorged there. So to test for jugular venous distension, you want them in a semi-fowlers, and you can describe how much of this venous distension, jugular venous distension has gone up when that seated position or semi-fowlers, and you'll note that in your documentation and communication. Again, as we come down and do a respiratory exam, you're looking at for symmetry, the exertion, rise and fall of the chest, whether there's any type of accessory muscle use, nasal flaring, open mouth breathing, pursed lip breathing, the ability for them to speak in complete sentences, or the inability to. We can also look for mental status changes. If they're getting too hypoxic, too hypercarpic, they're going to end up being more fatigued and more silent and somnolent. When we look at the chest wall, we're looking for that rise and fall, and we're looking for any subcutaneous emphysema, any type of scars, and any type of medical types of surgeries that they've done. We're also going to listen to their lung sounds, and as we listen to the lung sounds, we listen at the top, because that's where we hear the apices. So you just kind of run just underneath the clavicle and come back up here. So we're looking to see and listen to the lung sounds as we go down. We compare right to left, right to left, right to left, right to left, as we move all the way down, and then we listen to the bass, and then as we move towards this lateral aspect to hear the base of the lung field. Keep in mind that the diaphragm is here, and when they breathe in and out, that the diaphragm can move up and down. If we're listening way too low, then we're probably listening to the GI or abdominal section. So stay above and listen. As we continue to do our respiratory exam, it does take us down to the lower extremities to find out if they have any type of unilateral or bilateral edema or swelling, because the bilateral swelling could mean something such as congestive heart failure. Unilateral swelling on one side could indicate that there may be some kind of DVT blood clot or blood clot in the lower extremity on the venous side, and this could lead to some type of a pulmonary embolism. We'd also go ahead and have the patient sit upright, and so we can listen to the posterior aspect of the patient's upper torso and lung fields. And again, we compare from right to left, and we note the type of lung sounds that we would hear as we listen to their lung sounds. Additional things that we may be looking at would be any type of other skin changes. There may be some kind of cyanosis or discoloration to the capillary or nail beds, capillary refill. May need deality, but that would be more of a shock condition. We can also see some para-oral cyanosis. If we look at the gingiva, we might also see some grain or cyanosis there. This may all indicate that there is some type of respiratory problem. Keep in mind that we have some other diagnostic tools to help us with our examination. If we are capable, then we're going to put our pulse oximetry on, and we're going to get our Untitled CO2 monitoring to check and see if we're able to get that type of off-gassing that's going on.